Now, our first famous medieval doctor is Roger Frugard, the great Roger Frugard, working in the 1160s. Now, a rather obscure figure known to history as Roger of Salerno, despite the fact that he has absolutely nothing to do with Salerno. He's not born there, he doesn't work there, he doesn't live there, but he's known as Roger of Salerno. But his name is Roger Frugard. Now, he started to lecture on surgery in the University of Parma. Now, his pupils collected his lecture notes after he died and published them in 1180. And the team is led by a man called Guido of Arezzo the Younger, an incredible name. And they called this book of his collected lecture notes Chirurgia, or surgery. And it's the first book on surgery in Western Europe for some 500 years. Now, we still have 20 copies in existence, one from 1200 AD. Trinity College, Cambridge has a copy from 1209, the first time it was translated into Anglo-Norman, and it's got some great illustrations. Now, he appears to his students as a genius, correcting his predecessors' mistakes and deficiencies due to his consummate skill and intelligence. I just hope that one day when I die, that my students too will collect my lecture notes and write me so kindly into the historical record too, but I somehow have my doubts. Now, it's worth looking at some of the operations on offer in Roger Frugard's notes. Wound sizes are to be gauged by inserting a finger into the wound. He also shows a test for cranial fracture. Says that if there's no obvious swelling or depressions, then get the patient to stop up their mouth, nose and ears and blow hard, like so. Now, if there is an escape of air or other matter from the head, that would be a sign of fissured bone. Now, you might go, how crude? What? And it is, I suppose, crude, but it's remarkably effective. For those of you who work in medicine, then you might be familiar with the technique. It's called the Valsalva technique, and it's not meant to be used in NHS hospitals anymore. But when I was doing this talk for the British Biomedical Science Institute, then they did say that a couple of people were familiar, to my concern, with the Valsalva technique. But such was their confidence that the patient could be healed from a cranial fracture, that if the surgeon failed to help this patient, then under the law, the surgeon would be hanged. The patient was expected to survive from this kind of head injury. Now, that's a confident medical establishment. Even now, you'll be told that no operations without risk, and that every time you have an operation, there's a chance that you don't recover. But it's rare now for the surgeon to say, look, if you don't recover, then I'm going to die along with you. Now, to try and deal with these kind of head injuries, they develop non-sinking drills, because obviously, if you're going to, it's what we call trepanning, when you drill into the skull, very effective. One of the things that will kill you about a head injury is that if you start to bleed inside the skull, the blood will start to crush the brain, as it has to, obviously has to go somewhere, and it can't go through the skull, and so it builds up pressure that causes a headache and then starts brain damage and kills you. And so you have to drill a hole into the skull to release the pressure. Now, they've been doing this since the Stone Age, actually. When I was on honeymoon, I took my wife to go and see some of the skulls where in Stone Age times they drilled into the skull and the patient survived. You could tell the patient had survived because the edges of the hole had started to heal up. And some of these skulls have several trepanning marks, so some of them survived several of these operations. So that you have to drill into the skull to release the pressure, to stop the blood from crushing the brain. And so the medieval surgeon develops a non-sinking drill, because obviously the danger of drilling into the skull is that you might drill too far and go into the brain. So they develop a drill with a collar on, so that when you go through the correct distance of the skull, the collar hits the skull and stops the drill from going too deep and plunging into the brain. Now, the fracture could be enlarged via trepanning to allow the removal of bits of bone, with a hole drilled on either side of the fissure, and then the holes connected with the use of a surgical chisel, known as the spatumen. And they'd use this with a little mallet. Now, in 1330, a knight, Juan del Frogo, had 18 pieces of broken skull removed and survived the operation, which gives you some idea of just actually how skilled the medieval surgeon was. Moving on, if you look at the illustrations for Roger Frugard's book, then you'll notice that there's actually an incredible array of figures shown in the medieval doctor's book. The first recorded use of a locum, a temporary doctor hired in just to try and cope with crises or staff shortages. The first locum of medical history is shown in Roger Frugard's book. Interestingly, for those of you who work in medicine, locums in this time are always shown kneeling at the feet of the permanent staff. Just an idea, perhaps, if you want to introduce that. And also, we're told that doctors in this time period don't do home visits. If you read school textbooks on medieval medicine, they'll say that doctors don't visit their patients, and they say that the idea came from the great doctor Thomas Sydenham several centuries later. Absolute rubbish. If you look at the illustrations from the book of 1209, there's an illustration labelled "The Home Visit," which seems to me at least to really challenge the idea that home visits were invented in the 17th century. So why do these school textbooks say this? Well, we have to show to our pupils the idea that things started bad and then improved steadily through the time period. The idea that there's a straight linear improvement through history. You're not allowed to tell pupils that sometimes things get better and sometimes things get worse. But my experience of life is that things are always getting better and worse, and often at the same time. That there isn't a straight linear sense of improvement. And so in the GCSE history, you're told that medieval doctors don't do home visits, despite the fact that Trinity College, Cambridge has a book from 1209 showing a home visit. And so in the home visit, the doctor is checking for a head wound, recording appetite, sleep, bowel movements, and it says that any poor performance could indicate an injury to the brain. And they knew that by 1200 that different parts of the brain controlled different functions, and that an injury to one side of the head could lead to a weakness on the other side of the body. It also shows exploratory surgery, the body to be explored by fingers and a probe. And it's worth noting that in the pictures, by the way, the doctor is always shown in the illustrations on a high-backed doctor's chair, an ornately carved wooden chair. And in every single one of the illustrations, the doctor is shown in this high-backed chair, even on the home visit. Now, I suspect that's probably just that the person reading the book knew which figure was the doctor. I can't imagine that they had teams carrying around these ornate carved wooden chairs around the streets to do the home visits, as nice as that might have been for the doctor. But it always shows the doctor on their high back chair, which allows them to look down upon their patients. And other techniques that are shown in this book, you've got a fistula between the eye and the nose, and it says it could be cut open, then a feather dipped in egg white inserted into the wound. It says the roots of the fistula are then to be seared by fire, which is effective, and it says you're to use a bronze tube to protect the rest of the body. You put the bronze tube with the end where you want to burn, and then you get a red hot iron through the bronze tube so that you cauterize only the bit you want to cauterize. Effective, painful, but effective. It does say, however, in the book that the patient might refuse treatment because they might claim to be afraid of fire, and it does say what to do if the patient is afraid of fire. It says that if the patient is afraid of fire, get the bronze tube and pour quicklime down the tube. Now, quicklime, of course, burns on contact with moisture, which you will get in the human body. It will be far more painful than the red-hot iron. And it does say that you are likely to not only cure the fistula, but cure the patient's fear of fire, as they reckon if you have to do this a second time, next time they'll take the red-hot poker. And so 2 treatments in one.